An hour and a half.
Good morning. It is March 25th. This is House Healthcare. And we are pivoting back to S-163. So if you recall this, or no, 163? Yes, 163.
S-163.
S-163. So this was the role of advanced practice registered nurses in the hospital setting. And the questions were asked when we last took testimony is, why is this not being extended to physician assistants who also work in the inpatient setting within our hospital? And we've also received a lot of correspondence from physician assistants. Thank you for all your correspondence. We have seen them all. And so I thought I'd have some people in to kind of talk about the role of physician assistants and how they play into our system of care as advanced practice providers. And this issue came up a lot when we were talking about the emergency evaluations. And, I don't feel like maybe at that time we explored quite as deeply as we should have, but this is a great opportunity for us. So starting with Dr. Greenberg from Board of Medical Practice, did you want to come up?
Zooming here.
Yes. Good morning.
Good morning.
Thanks for coming.
Thank you for having me, Madam Chair, committee members. My name is Matt Greenberg. I am here on the behalf of the Vermont Board of Medical Practice. I'm currently the chair of the board. I am an emergency physician. I have 25 years of experience as an emergency physician. The last 15 of those have been here in central Vermont. I've been on the board now for about 4 years and recently became the chair. I was initially asked to come here today to talk to you about the board's position on this. Unfortunately, this topic came up since our last meeting, and I cannot do that because the board has not had a chance to talk about it. But what I can talk about a little bit is about PAs, which are under our authority for licensing, and how they are licensed, a little bit about their training and their scope of practice, and hopefully just answer any questions that you may have. I think I should disclose that in 25 years, I have seen a lot and worked with a lot of nurse practitioners, PAs, EMTs, paramedics. I've participated in the education of more than, several hundred probably at this point. I've been the primary preceptor through the University of North Dakota Physician Assistant Program. I have also been a primary preceptor through the Rocky Mountain University Nurse Practitioner Program. So I have worked both sides of the education system. I think that, sure.
Have you taught medical students too?
I have taught lots of medical
So
students.
you have that whole,
Yeah, medical students, EMTs, paramedics, nurses. So I've done a lot of education.
I didn't want to
Thank you for
interrupt.
being a preceptor because I know
Yeah, I was
that is a
thinking,
challenge.
whoa.
I don't know what that means.
preceptor.
So the preceptor in the clinical setting would be the chief medical person that oversees someone's education in clinical setting, sort of like, the main teacher in a classroom setting. So when I work with students, they will go see a patient, they will present it to me, we'll discuss the medical care. It's sort of the process of training a clinical practitioner.
Great, thank you.
I think what I would say is that, and again, this is more me speaking because I can't speak for the board because we have not discussed it. I think the leap under this bill from physician to non-physician is probably a much bigger leap, a bigger change than it would be to discuss PA versus APRN. Often in the hospital settings, APRNs and PAs fill the same role. They are seeing inpatients right now. They're doing most of the work that an attending physician would do, usually now by law, under the authority of that physician for final say, final billing, and those sorts of things. Obviously this bill would open that up so that physician role would not be necessary. PA and APRN training is a little bit different. I would say that PA training is a little bit more like physician training. It's typically 2 years. It is generally contiguous. So it's a 2-year block. People tend to, you're not working full time, or maybe you are, but afterwards you're doing school full time. There's a set block of non-clinicals, meaning book work, learning your physiology and your pharmacology and whatnot. And that's usually several months, followed by several months of clinical. I will say that physician assistant programs typically are hospital based, meaning a lot more of their clinical work is in the hospital rather than the outpatient setting, although that is variable. I will also say that the PA training is probably a little bit more consistent across programs right now, only because there is a single accrediting association for PAs, and it's been around a little bit longer. So I would say that in my experience, there's a lot more variability in APRN training. And I'm not saying variability is bad, but the credentialing really limits the way. So somebody coming out of PA school has a certain level of understanding in clinical practice that's expected of them. Typically, that's on the order of about 2,000 hours of training with an estimate of between 1,000 and 2,000 patient encounters. Just for comparison's sake, so everybody's aware, the AMA states that physicians come out of training with about 15,000 hours of training and somewhere between 1,400 and 3,000 to 4,000 patient encounters. Proceduralists are generally expected to have performed about 1,000 procedures. So there's a fairly big difference between physician and PA. PA and APRN are much more similar. The estimated hours of training for an APRN is about 1,500. So 1,500 for an APRN, about 2,000 for a physician assistant. Again, these numbers are very variable. Where people come to become a PA is a little bit different. If you think about an APRN, that's somebody who's already become a nurse, already has a graduate degree, or has a associate's degree in nursing, and so probably already has a full-time job as a nurse, and then is becoming an APRN on top of it. Typically, the pattern of PA training is that it's somebody who's coming from a medical background, whether it's a medical scribe, medical assistant, a technician in the hospital, a paramedic, who basically puts career on hold to do a contiguous 2-year program, graduate master's level program, and then is going to come out with that graduate degree. After that, it is expected that they would pass a national board exam. It's only offered by one organization. APRNs have 2 separate accreditation, 2 separate boards that they could take. And then once they pass that, then they would approach a licensing organization such as the Vermont Board to become licensed to then practice. What the board does when we take an application, we look at all of their schooling, we make sure that they have completed everything that is a requirement. We make sure that they have passed their exams, make sure that they don't have a criminal record, those sorts of things, similar to what we would do for a physician. And then they can work on getting a license. I think probably the biggest difference, at least in Vermont, it's not the same in every state, between PAs and APRNs, is that we require a collaborating physician to sign off saying they are available at any time to be involved in patient care with that PA. Doesn't have to be in person. They don't have to be right there in the clinic or in the hospital with them, but they have to be available. Now, in the practical sense, what happens, particularly on an inpatient team where a PA is part of that team, is that there'd be one person signed off legally as their primary collaborative physician, and then several others that are sort of associate collaborative physicians. So that way that that PA can participate in the team. Another portion of that role as the collaborating physician is that there's some intermittent feedback and evaluation, whether that's just discussing patients, looking at numbers, returns, et cetera. So there's sort of a feedback. That does not currently exist legally with APRNs. I will say that each hospital can do as they will. I'll use my own hospital, for example. In the ER, I have both PAs and NPs working with me, and we have the exact same requirements for them. In the ER, we do things based on triage level. Anything above a triage level 3 needs to be discussed with the physician. So hospitals can have, their own sort of regulation on top of it. Hospitals will also independently credential practitioners, whether that's physician, PA, or APRN. That credentialing process is yet another step to check on education, background, experience, and it's just one more role of looking at them. So I probably just leave it there and hopefully answer any other questions that you might have. But I think, again, my primary point is that the leap going from physician to non-physician is probably the big decision. Once you've made that leap, I think PA to APRN, I don't want to say equivalent because they're not exactly the same. They have different philosophies in their education, but I think that the amount of training that they have is similar. The amount of responsibility, the roles that they're currently undertaking in the hospital is essentially the same. So I think that if you're going to give that responsibility to APRNs, it makes logical sense to give that responsibility to PAs.
That's really helpful. So the big decision is whether or not we do this bill at all, rather than who it is that we're identifying.
In my opinion,
One,
that's
yeah.
the question, yes.
Okay. Thanks for putting the pressure on. I have a question about the licensure of physicians. And maybe because this has come up in some other topics and it's not relevant necessarily to this bill. So a physician assistant has to have a collaborating physician. And, I've looked up several of their licenses before, and their licenses actually list who their collaborating physicians are. And there can be multiples. Does the Board of Medical Practice track from a physician standpoint how many collaborative agreements an individual physician has?
Not to my knowledge. But we do track, and every year some of our interactions have to do with not having an appropriate, that's an important step for the physician assistant to maintain that, an appropriate person that still has a license. We run into not infrequently where a physician moves out of state and their collaborating agreement doesn't get changed. But I don't know, and I probably have to clarify that with David Hurley, the executive director, but I don't think there's back looking to see how many physician assistants are under any single physician license.
Does the nature of the collaboration, I know that nurse practitioners after several years can practice independently. Could a PA establish like their own practice and just have a non-affiliated provider be their collaborating provider, or is that?
Yeah, they would still need a collaborating physician that is of reasonable proximity to them. And I don't remember exactly how that's defined in the board, but they have to be a practicing physician at that location. They can't be just a name on paper.
So my understanding of this bill, limited understanding of this bill, is essentially that, right now, PAs, APRNs, they can be the attending provider while somebody is in inpatient status, but they cannot do the admitting and they can't do the discharge. They can, but they gotta have it signed off on.
Yeah, and so in practicality, what happens?
Allow that to happen.
Correct, and that's exactly what happens. In practicality, a PA or an APRN may go see the patient, write up the whole H&P, write all the orders, and then a physician will come in talk to the patient briefly, and then write an adjunct note with that. I will say that this probably is a bigger issue for the critical access hospitals in Vermont.
Yeah, that's what we've heard. I don't think we were quite aware that they're being staffed 24/7 usually with a advanced practice provider. Leslie,
Thank you. Would you be willing to share your testimony so that we can review it? Because a lot of those numbers went by fast.
Absolutely, that was my intent. I unfortunately didn't finish this until about 11 o'clock last night.
Sounds like us, so no, we're good. Thank you.
I will share it. I'll send it to Tosh as soon as
Yeah,
I'm
that'd be
done.
great. Can you remind me what hospital, what year are you working in?
I work in Central Vermont.
Okay, so I'm trying to understand the bill too, and it looks like the patient bill of rights is what the bill is about. So that's what I'm trying to balance. I actually did a little bit of a dive into why did we need a patient bill of rights? And I'm old enough to have lived through the whole history of that. I'm a nurse practitioner, retired, so I lived through that, so I understand it. So what I'm understanding is that we're trying to acknowledge what's already happening. And that by adding the APPs into the patient bill of rights, which is what I think we're being asked to do, is that we're acknowledging what's already happening. Is that not right?
I think that's mostly right. I think that currently, by having that physician oversight still necessary, you are still getting a little bit of physician oversight. I mean, you're getting it on paper, but I think that you're really getting a physician that has looked at the patient and said, I agree with you, or have you considered this? In medicine, the biggest enemy is not knowing what you don't know. You're not going to make a diagnosis if you're unfamiliar with it. And familiarity with diagnoses is really all about experience. How many times have you seen that particular rarity or whatever? There's so many unknowns in medicine. Everybody has different genetics. Everybody has different exposures to medicines, toxins, substances, whatever. And so, something can look absolutely like something else that's very common and not be it. And if you've never seen that, then you don't even think about it. And I think having the physician oversight, and that's the biggest difference between physicians and APPs is that amount of training.
No, I hear you, but isn't this bill, and this is what I'm trying to understand, talking about the interaction between the attending and the patient? And what's going on in that background is not what this bill is about, is what I'm trying to understand. And it's more about telling, like I say, patient bill of rights is telling the patient, well, who's in charge? And that patient may never see the attending when they're there because the attending is, doing their work and then the APP is doing all the work except, maybe consulting or whatever, or they're in the critical access hospital and there's no one there anyway. So that's what I'm trying to understand is it about the interaction between the patient and the clinician, and that the credentialing process, which you mentioned, is what actually is the underpinning of what goes on in that particular hospital.
Yeah, the credentialing is really important. And my understanding after reading the bill, and probably you've been doing this a lot longer than I have, is that this Bill of Rights is being used as a surrogate to determine who has the authority to sign off on those patients. And so it is the sign-off authority, and what has in practical speak been happening with the APRNs and PAs seeing and doing most of the work. But there is still, by requiring the physician to sign off and be involved in it, and they're still supposed to be seeing the patients, so there should be patient contact. But the theory behind that is that there is that bit of oversight and that maybe added experience. Now, we could absolutely, and I'll freely admit, run into a situation where you have a brand new physician and an APRN or a PA that's been working for 30 years. And honestly, the roles are kind of reversed. But the law still says that the physician has to sign off on it. I think that's less, because still, even a brand new physician, coming out of 4 years of medical school and 3 to 7 years of residency is going to have a much broader experience to draw upon. But that's my understanding of the bill. I hope I answered your question.
Yeah, I mean, I'm getting the surrogate word, that was a little bit of a,
Well, that's what surprised me is when I heard briefly about this bill, about can you talk about a bill that's going to talk about PAs being able to admit? And then when I actually looked at the bill, it's actually the bill of the patient bill of rights. Now, what I don't know is, are there other bills out there that describe this relationship of who is the primary attending? And I don't know enough of the legal background to know whether that exists or not. So my impression was that this is the surrogate to define who is your attending when you're an inpatient.
Yeah, I don't think there are a lot of bills out there about that, but I think we're learning about the credentialing process in hospitals, and that each hospital may have a different version, and that's appropriate and makes sense. So this to me is about patient, as I say, going through the history of, when patients were really excluded from the medical conversation. Now, is it important for them to understand who is truly taking care of them?
Yeah. And I think that's key. I think it is really important. I will just add one point to the credentialing. Credentialing is overseen by CMS, usually through the Joint Commission at most of our hospitals or other organizations. So there are a lot of criteria that are very stringent and dictated.
Yeah.
But yes, each hospital does their own credentialing.
Yeah. So then maybe the question comes up, what does this bill change in reality, in practice? And maybe not.
Or does it codify current practice?
Yeah, or does it codify current practice? Yeah, I think that's right.
Can you, at first, your testimony, I really got the impression you were trying to differentiate between physician's assistants and APRNs. But that you said the initial leap of faith was taking away from the doctor itself.
Yes.
So that's the leap of faith. And then how are you differentiating the two?
Yeah, I think that the biggest difference between PAs and APRNs has to do with their training and the philosophy behind them, right? APRNs are coming from the nursing role and the nursing model, which tends to be a little bit more relationship related, whereas the PA role is modeled under the physician training model, which is a little bit more academic and a little bit more regimented, perhaps. I think also the bigger difference right now, and I think this is going to work its way out over the next several years, is I think there's a lot of variability. There are a lot of online training programs to be APRNs, whereas I don't know of any, could be wrong, but I don't know of any that are PAs. And that sort of delves into the structure of how the training philosophy is. Having been a preceptor on both sides, I would say that they are definitely, the training regimen was a little bit more strict on the PA role. And again, that's just an N of 2. So I think that there are distinct differences, but I think overall, particularly after a couple of years, there's not much difference.
And can you just clarify 8? Like it actually says professional case records will be compiled for all patients and signed by the attending physician or an APRN.
And we're thinking of adding or a physician assistant.
Okay.
It's not there yet.
Okay.
Thank you. Thank you very much. All right. We have Lee Morissette and Leah Skypeck. And I think, did you guys want to testify together, I had heard, or, okay. And so welcome and grab one of the extras. Thank you for coming in.
Good morning, Madam Chair, and distinguished members of the Vermont Healthcare Committee. My name is Lee Morissette. I'm the president of the PAV Association, and I practice emergency medicine at several rural critical access hospitals here in Vermont. We appreciate the opportunity to testify in reference to House Bill 163, amending the Patient Bill of Rights to add APRNs and requesting the inclusion of PAs. As discussed in prior testimonies by OPR, VAS, VMS, and the Vermont Nurse Practitioners Association, this bill was intended to reflect current practices of inpatient care within Vermont. Throughout Vermont, APRNs and PAs are an integral part of inpatient healthcare teams. In many areas, they are sole providers delivering care to patients from admission throughout the inpatient period to discharge home. As Dr. Greenberg just outlined, medical license for PAs are issued by the Vermont Medical Board of Practice. And on the board, there is a PA representative. Prior, several years when I came to Vermont 10 years ago, the chair of the Vermont Medical Board was a PA. Like APRNs, PAs are licensed to conduct physical exams, order, interpretation, diagnostic testing, diagnose medical conditions, develop and manage treatment plans, prescribe medication, and discharge patients with home care plans. Act 123 of 2020 allows PAs to function as admitting providers as well as a clinician of record. Under 26 VSA 1735A, PAs no longer require a physician supervisor, but now require a practice agreement, as Dr. Greenberg outlined, which is based on the patient's, the PA's clinical education, training, and experience. Thank you, Dr. Greenberg, for summarizing the PA training. I'm not going to go into that as I outlined in my brief. But again, we are under the medical model similar to physicians. Many of the prerequisite to be for PAs, actually in 1965, the prerequisite was you were either a Navy corpsman or an Army medic or a nurse. I was a Navy corpsman for 25 years. And the requirement was for most PA programs is you have to have between 2,000 and 4,000 hours of direct patient care experience, as well as your bachelor's degree, similar to applying to medical school. As Dr. Greenberg outlined, the didactic period, anatomy, physiology, pathophysiology. We also do gross anatomy labs side by side with medical students. Clinical medicine, pharmacology, patient assessment, diagnostics, and procedures. And then our second year can range anywhere from 12 to 14 months doing clinical rotations, family medicine, internal medicine, general surgery, emergency medicine, pediatrics, women's health, behavioral health, and then there's several electives. As Dr. Greenberg had mentioned, I've precepted PAs and nurse practitioners in emergency medicine for years. And it's very similar at that level. Vermont PAs can serve patients and serve as clinician of record without independent practice. We know that was referenced, but Vermont in previous testimony, but Vermont law does not require independent practice authority to admit and manage hospitalized patients. Since PAs practice in collaboration, not supervision, hospitals can credential and privilege PAs for admitting and be the clinician of record functions as long as those duties fall within the PA's education, training, experience, and the practice agreement with the hospital. The Vermont Patient Bill of Rights creates a barrier to this by specifying only physicians can be designated as a clinician of record. This prevents PAs from serving in that role even when they are qualified. Instead of excluding PAs, hospitals should decide what each provider is allowed to do based on their training and experience through their bylaws and credentialing process. The Vermont Practice Act 26-117-35A say that PAs, as Dr. Greenberg outlined, must have a practice agreement for physician availability, consultation by phone or some electronic means at all times, communication decision-making process and scope is based on the scope of practice based on the PA's education, training, and experience. What this means is PAs do not physically require a physician to be present, nor do they need direct oversight to perform clinical functions, including admitting, rounding, coordinating inpatient care. I'd like to ask that my colleague continue the testimony from here.
Good morning, Madam Chair, distinguished members of the committee. Thank you so much. My name is Leah Skypeck. I'm a critical care physician assistant PA at Rutland Regional Medical Center. I'm also the medical director of the intensive care unit. I've been practicing there for 8 years. Prior to that, for 5 years, I practiced at Dartmouth Hitchcock in the medical ICU there. And before starting my professional career, I did a critical care residency program at Johns Hopkins. So I appreciate Dr. Greenberg's explanation of PA education. And I just want to point out that more and more often our PAs going to additional postgraduate training for subspecialty services, as I did. My hope is to describe to you the inpatient service model at Rutland Regional ICU. I hope that will illustrate the role that PAs, APPs, I should say, play on the inpatient service. So Rutland has a 13-bed ICU. About 10 years ago, this unit was staffed by one intensivist physician 24/7 for a week. That is neither good for the intensivist nor the patients. So in 2018, Dr. Harvey Reich reached out to me. I was at Dartmouth at the time and said, hey, I need some help. I can't recruit someone to work these hours. It's not sustainable. What can we do? So at that point, we developed a APP intensivist hybrid model to cover the unit 24/7, 365. Better for patient care, better for patient safety, better for provider wellness. So fast forward to today, I have 4 intensivist physicians and 4 APPs. Currently, 3 are nurse practitioners or APRNs and 1 is a PA, but there have been times where that APP group has been 3 PAs and 1 APRN. And the key piece to this is that critical care patients don't schedule a time to get sick, right? So if it's 2 a.m. and a PA is on, I am going to provide that patient with the same care, the same quality of care as 2 p.m. on Friday. And that is up to the hospital's credentialing committee to vet those applicants to make sure that their privileges, that they are trained and qualified to perform those duties so that the quality of the service is the same no matter what day of the week and what time. These are some of the sickest patients in the state. They need timely care. So it is not realistic at 2 a.m. if I have a patient that that needs 3 procedures, a breathing tube, a central line, a chest tube, that needs to happen. And that the reality is the intensivist, that is my resource at home, which I value enormously, is not going to be able to come in and see that patient. I need to do what I need to do. And sometimes that means transfer to a tertiary care center. So I've admitted the patient, I've managed their inpatient care, I've done procedures, and I'm transferring them to get life-saving interventions. That needs to happen on my service. And there is no room in that scenario for me to get on the phone with the attending intensivist and get approval. Now, look, I agree with Dr. Greenberg. A new grad right out of school, APRN or PA, should not be doing this, right? And that's the responsibility of the credentialing committee and the bylaws of the hospital. I think we've done a good job talking about the differences between APRNs and PAs, and the reality is they're more alike than different. I know at Rutland, we are working really hard to develop a collaborative relationship between PAs and APRNs. We have an advanced practice provider advisory council on which I sit to develop a really strong relationship, because the reality is the workforce in Vermont is small, right? And so I want to staff my ICU with the best providers, whether they're an APRN or a PA. And if this bill includes APRNs and not PAs, that's a real sort of operational workflow barrier that I can't create 2 systems for 2 different types of providers that essentially fill interchangeable roles. So I think we've covered a lot. If there are any questions about Rutland specifically, our relationship with our collaborating physician, which, by the way, I know the APPs at Rutland feel is a bonus. It is a resource. It is better for patients, right? But it shouldn't be a burden or a barrier to access to care or efficiency.
Is there any requirement that a PA, that your collaborating physician actually be, I mean, I'm sorry, I'm looking at your license.
Yeah.
Dr. Stingo, I think?
Yes.
Yes. So is there?
Great guy, by the way.
Who was that?
Great guy, by the way.
Yeah, okay, I bet he is, and he doesn't want to be disturbed at 2 a.m. Is there any requirement that your collaborating physician actually be someone who I'm assuming that Dr. Stingo is also maybe a hospitalist at Rutland Regional or intensive care. So is there a requirement that your collaborating provider be employed and also working in the same environment that you're working, where you're collaborating with? Or could you just have, rando doc? I'm gonna pick on a specialty. We always pick on urologists in this committee for some reason.
Yeah.
Could random urologist who practices in Montpelier be your collaborating physician?
I'm unsure if that is permissible, but the bylaws at Rutland require that my collaborating physician have the same privileges in both directions. So that my understanding is that's regulated by our credentials and privileging committee and the bylaws, of course.
We don't have the hospitals here today, but I'm assuming that all hospitals in the state have bylaws over
Yeah.
and
Oh, yeah.
credentialing requirements.
Yes.
They have to as part of their malpractice.
Part of their license.
Yeah.
The Joint Commission, I think, thinks, yeah.
Oh, Tupper, his question.
I'm assuming something, so. When you transfer the person to the life-saving services that they need, is there a physician that does that?
That's me. I'm a PA and I will do that because the patient needs it.
Yeah. Will you actually perform the service with all that stuff you were talking about?
Yes. Yeah.
But you're not able to actually sign off on it. It has to be signed off as somebody else currently.
Correct.
Okay. Go ahead, Leslie.
Thank you. Could you take care of me?
Hopefully it won't happen.
You too. Very cool. Could you
You're
talk
never
a
in
little bit
it.
about what the patient perceives about who's in charge? Because I think this is kind of what the conversation is about from the
Mhm.
patient bill of rights, although I'm trying to understand the surrogate thing and I'm not there yet. So if you
Yeah.
could talk about patient perception, about who's in charge
Yeah.
and what, yeah,
Great question. And the short answer is it's confusing.
yeah.
I think for my service, most of my patients are sedated, intubated, not particularly conversant, but it's their families that get confused. And we do our best, despite it being sort of high stakes, high stress times, to explain, I'm working with, we're a group. And critical care by nature is team-based. We don't have turf wars. The more brains thinking about a patient, the better. But it is confusing for patients. And I think, but what matters most is that the provider, no matter who they are, what their title is, treats that patient with dignity, respect, communicates. And that matters so much more.
So how do you communicate to the family, let's say, because of who's in charge?
Yeah, I say, I'm Leah Skypeck. I'm a critical care physician assistant. I'm your provider on service tonight. I'm going to
ABCD.
and get consent for, and here's the plan. And then at shift change, if able, I'll say, Dr. Stingo is on in the morning. We're going to talk about your case and he's going to take it over from there. And I'll see you at 7 p.m. tonight. You try your best to explain that this is a team sport.
Does anything change if this bill passes and how you communicate in that case?
No. And it just aligns with what we're doing.
Yeah, that was kind of the question.
Yeah.
So Dr. Huber mentioned that this is a bill for surrogate. And I'm not sure I understand that. So that's what I'm wondering what your thought is about that.
I don't know that I understand that either. I think our service provides best practice. The reality is I've been doing this for 15 years and 3 of the intensivists have been doing it for 3. We use each other and collaboratively. those newer intensivists are not afraid to call and ask for help. Yesterday, one of the newer intensivists was on and was getting overwhelmed. There was a cardiac arrest patient in the ED that needed to come up. He had 6 other patients, very active. He called me. I came in. I admitted that patient. I talked with the family. I did the whole H&P. I wrote all the orders. I did a procedure.
And at all that time, they thought you were kind of in charge.
Yeah, I explained
Yeah.
who I was. and
Yeah.
a part of the team. And when I left, I said, Dr. McNinch has got you. I filled him in, on everything. But the reality is he couldn't be in 2 places at once. That's not good for patient care.
Daisy, you had a question, Daisy?
No, you heard me thinking really
Oh.
loudly.
I'm really good now. I can just
She is really good. I was just sitting here, as you were explaining that situation, imagining, okay, so it's like if Dr. Robbie.
I keep going to the pit also, by the way. Like, I'm just saying it. It's that guy.
Yes, and this is just some of the most helpful testimony. I just, really grateful for what you all do. And also, this is just connecting so many dots and just really appreciative.
Welcome. My pleasure. Truly.
Any other questions? Really helpful. Thank you.
Thank you for your time.
Thank you. Good morning. Good morning. Kind of wanted to get MS's thoughts on, since you all represent physician assistants as well.
Yes, Joseph Barnard, Vermont Medical Society. I don't think I have a lot to add, I will actually say. Thank you for inviting me back. I did testify last week, I think, on the bill. And I will just very briefly, I guess, reiterate the comments I made then and what you just heard. I echo all the testimony you just heard. I really appreciate everybody going before me. We agree with Dr. Greenberg and the PAs you just heard from, that the bigger question is sort of, is the bill moving forward? And then if yes, we agree that it doesn't make a lot of sense sort of philosophically or workflow wise to distinguish between PAs and APRNs in terms of their role in providing inpatient care. So again, we would suggest, if the bill is moving forward, that they both be included. And I am happy to answer other questions.
Leslie, but I will say that if the bill does move forward, at least we won't have to come back to it in 2 years and do this all over again. Go ahead, Leslie.
So does that mean you're not neutral anymore? Have you changed?
I think on the overall moving forward on the bill, our position is still neutral.
Okay. And could you talk about the Joint Commission and let people understand the role they have in hospital credentialing so that we could feel confident that that's oversight is happening?
I don't actually know that I can give you specifics, as I am not a hospital regulation expert. I will say I do know that, so the Joint Commission comes in and surveys hospitals. They have hundreds probably of requirements that each have numbers. Unfortunately, it's proprietary. So I have actually tried at times to look up some of the requirements, and if you don't pay for their service, you can't actually read all of them. But they do require a medical staff. They require medical staff bylaws. They require a credentialing process. That much I do know. So every hospital is required to have medical staff that then does the credentialing, the privileging, and outlines in bylaws, a written document, how they implement that.
I don't know, maybe we could ask Devin, but yeah.
Ask Devin.
Yeah, she might know more about it. I just curious if there's any oversight on credentialing, but you might not know that there are some sort of baseline requirements.
Yeah, as of this morning, I can't go give you any more detail this morning of what specifically they say. It may be something that Devin has or has access to. I know she does send her regrets this morning. She is, I believe, in a hospital budget meeting with the Green Mountain Care Board.
Speaking of hospital budgets, I'm going to ask an indelicate question, which I don't think you could answer, but I'm wondering if maybe the PAs or even Dr. Greenberg, when I'm always thinking about money. When a attending does an admission, and if it's a physician signing off on an APP's, essentially the APP has done the work, but there is that element of the physician has to sign off on it. Is the admission, I understand that, like sort of the daily inpatient care would be billed under the person doing it, but is it billed under the attending physician, the admission, or the discharge? Or is it billed under the, do we still use the term mid-level provider?
No.
Okay, we stopped using that. Okay, I'll stop. I'm going with APPs. Who's they get billed under? Because I'm thinking about reimbursements.
Yep, great question. And I know you touched on Medicare last testimony. And we're trying to explore that because of some recent changes with something called an AI modifier. Which used to signify who's the consultant, who's primary. And when the consultant code went away, the AI modifiers were being attached to APPs, and that sort of triggered what's this. So I think it's evolving, but and I'm not an expert on billing, and I think the answer is it depends. But I think that the hope is that state statute, isn't the barrier when federal law catches up.
Okay. Go ahead, Pepper.
The neutral position. Does that apply to APRNs as well as the physician assistant?
Yes, correct. Because that was the underlying bill our board was looking at. Mhm.
And why is it neutral?
It's neutral because our board understands the motivation behind the bill and the sort of catching up with day-to-day practice, but also had some more substantive concerns that it does, even though it's not a scope of practice statute, it's the Patient Bill of Rights statute. And I will add, it's actually two sections of statute. The language is kind of repeated into, it's the Patient Bill of Rights and the hospital licensure statute. So it actually is also a licensing statute for hospitals that is being changed. And that there is or could be, it's sort of like the testimony you just heard from Dr. Greenberg, some substantive contribution of that admitting physician role. That we've heard both opinions, and we kind of balanced that with, yes, in some ways it's a paperwork requirement that may not really reflect who's primarily providing the bulk of the care to that patient. However, it is currently, even though it's in kind of weird sections of statute, requiring a physician to have their eyes at some point on what happened in that course of that patient's care, and that could provide some helpful touch points to ensure ideal patient care.
And physicians, as we sit here today, are actually doing that now, aren't they?
Correct. They're required to do that now. Correct. And so we had some members who felt very strongly that that was a really important aspect of ensuring best patient care in the state. And then we had other members who felt very equally strongly, no, this is more of an administrative paperwork requirement. It's actually a burden on both the APPs and the physicians, and we're supportive of it being eliminated. So we had basically a pretty even split, and ended up saying, you know what, we're in the middle, and we leave it to your wisdom of which way you want to go.
Distinguished.
You're the distinguished committee members that make the decision.
Yeah, I see you, Leslie, but can I ask a pointed question? Is this a turf war?
Well, that's what surrogate worried me.
No, I mean, I would not say that, in that there is more than enough patient care to go around.
Mhm.
It's not a financial, it's not a, we want the work, it's not a, we want the billing. It was not, I don't see it that way. I see it more of a, is this helping ensure best patient care for the sickest patients in our state who are inpatient?
Not, is it about the billing or is it about the financial? Is it about the hierarchy and maintaining the hierarchy?
I did not, we received close to 100 comments from our members. They were not hierarchical, but I will say there was again, a difference of opinion about whether the difference in training and experience matters and how that impacts patient safety.
Leslie, did you wanna, and then we gotta get going to the plus.
Yeah, we have to go to the floor, but it's a question for Jen, because I think you just sort of said something about this having impact from other aspects of the law or other parts of the statute, and I just didn't know how that impacts, and if at some point we could if we need to think about that.
And for the Office of Legislative Counsel, I think I would need more specificity on which other.
Yeah, like what you're thinking, I'm curious to know that.
I think the point I was trying to make is just that there are two sections of statute that this bill is amending, both the Patient Bill of Rights and the hospital licensing statute.
So where is that? And that's what I'm trying to find.
So section 1 and 2 of the bill deal with the Patient Bill of Rights. Section 1 is just the definitions.
Yep.
And then section 3 is amending the hospital licensure chapter.
License requirements.
So the license requirements, right, that is in hospital license.
So that adds the APRN or the APP to that. That's
Yes, so
Five, so five.
our existing law, all patients admitted at the hospital must be under the care of and under current law, state registered and licensed practicing physician as defined by the laws of the state of Vermont.
Okay. So that's
And physician under both types of physicians and APRNs, and then under discussion, potentially physician. And similarly around the case records.
Yep.
Right.
Thank you very much.
Thank you. Yes. So we'll come back to this at some point. And anybody, if you want to be thinking about whether or not you feel as though there's more people you need to speak to, more testimony you feel needs to be had, and I'm looking for your input on that.
So the APRNs testified in the Senate. I don't know if they testified here yet.
They testified the first day.
Oh, did I miss it? Yes, when I was on.
That's right.
Okay.
That's right.
I'll go back to it. Okay, thank you.
All right, we can go off of live and obviously no more committee